Good day. I am Dr. K Gireesh, physician, neurophysician and neurosurgeon. This is the RNA series number 59. RNA is nothing but random questions in neurology and neurosurgery with answers by Dr. K Gireesh. This is to benefit the practitioners of neuroscience and the medical field and for a lifelong learning and also for public awareness. In this series, I am addressing the origin of the corticospinal tract and its features is the main voluntary motor pathway that originates predominantly from the cerebral cortex, especially the motor areas. The primary site of origin is the primary motor area, area number 4, located in the precentral gyrus, which is the major contributor, almost 30 to 50% of the fibers. It is responsible for the precise voluntary movements. Premotor cortex and supplementary motor area. From there also fibers do come out. That is around area 6. This contributes to the planning and coordination of the movement. Then fibers come from the primary somatosensory cortex, areas 3, 1 and 2. This provides input for the modulation of sensory feedback during movement. So from area 4, area 6 and area 3, 1 and 2, you find the corticospinal fibers originate. The maximum fibers do come from the area 4. So the primary motor cortex will be around 40%, premotor and supplementary motor area will be around 30%, and somatosensory cortex will be another 30%. It arises from the pyramidal neurons, especially in the layer 5 of the cerebral cortex. So from the cortex, it descends down to the corona radiata, internal capsule, cerebral peduncle, pons, medulla, and then it decussates and goes down to the spinal cord. The corticospinal tract originates mainly from the primary motor cortex, that is a precentral gyrus, with significant contributions from the premotor and the somatosensory cortex and forming the anatomical basis of the voluntary motor control. Understanding the corticospinal tract becomes clinically very powerful when you localize the lesion. The hallmark is the distinction between the upper motor neuron and the lower motor neuron sign. The upper motor neuron, the features are all upper motor neuron lesions. The corticospinal tract is involved above the anterior horn cells of the spinal cord. So wherever in the corticospinal pathway it gets affected above the anterior horn, you get the features of the upper motor neuron lesion. The anterior horn and below, it may be the anterior horn, the roots and the nerves will become the lower motor neuron lesion. So upper motor neuron lesion, the tone, let us see the tone, reflex, plantar, the muscle bulk and the fasciculations. Tone in an upper motor neuron lesion, there will be spasticity. In lower motor neuron, there will be flaccidity. In reflexes, upper motor neuron, there will be hyperreflexia including clonus. And in low motor neuron, the reflexes will be absent. Plantar response, upper motor neuron will be extensor, Babinski, and in low motor neuron, it will be flexor. The muscle bulk, in upper motor neuron, there will be mild wasting, especially disuse atrophy, whereas marked atrophy will be there in low motor neurons. Fasciculations will be absent in the upper motor neuron, whereas low motor neuron, it will be present. Now, even the lesions, wherever it occurs, may be cortical or in the corona radiata or in the internal capsule, the brainstem, the spinal cord, you see that differences will be, each area you will find will be associated signs which you can tell which level it is involved. Like the cortical lesion, if the corticospinal tract is involved in the cortical, that is a motor cortex, like as a result of tumor or infarct, you get a contralateral weakness of the face, arm and leg, or arm more than the leg, especially if it is cortical, MZA territory. Patient may have seizures. So cortical hemiparesis with cortical signs. Then comes the internal capsule, where all of them become in a compact bundle. There will be a dense deficit if it occurs. And the causes are the lacunar infarct, hypertensive bleed, The features are a pure motor hemiplegia, which will be a contralateral face, arm and leg equally involved. No sensory or cortical signs. And this is a classic lacunar syndrome. Then comes the brainstem. You get cross finding. One side the cranial nerve, opposite side the body weakness. So ipsilateral cranial nerve palsy with contralateral body weakness, like Weber's syndrome with the midbrain. Same side third palsy with a contralateral hemiplegia. Pontine lesions, facial weakness with a contralateral limb weakness. That is a crossed hemiplegia. And in the medulla, where the decussation occurs, if a lesion above the decussation, it will be a contralateral weakness. If lesion is below the decussation, it will be an ipsilateral weakness. Then comes the spinal cord. Hemisection of the spinal cord, that's the features of Brown-Sequard syndrome. Ipsilateral weakness below the lesion, ipsilateral loss of vibration and proprioception, and contralateral loss of pain and temperature. If it's a complete cord injury, initially there will be a spinal shock, which will be a flaccid weakness. Later, you get a spastic paralysis, especially UMN signs below the level. A classical pyramidal signs, Babinski sign, clonus, spasticity, and loss of fine skilled movements, especially the distal hand, will be seen. The corticospinal tract is very crucial for the fine, precise voluntary movements, especially the distal muscles of hands and fingers. And these are the features of the corticospinal tract, and the lesions. Phase is involved, usually it is a cortex, internal capsule, and the cross signs will be the brainstem. Ipsilateral weakness below the lesion, spinal cord. Pure motor hemiplegia is equal to the internal capsule lacunar infarct. And Babinski, always UMN until proven otherwise. So, the corticospinal tract is the final common pathway for the voluntary movement, and its lesions produces the upper motor neuron syndrome with predictable localization patterns from the cortex to the spinal cord. So that is in brief about the features of corticospinal tract. Thank you very much.